Welcome all. Today we will discuss about the chemotherapy in gynecology, very frequently asked short note in your examination. So chemotherapy. Chemotherapy is the use of cytotoxic drugs to selectively destroy malignant cells while causing minimal irreversible damage to normal tissues. What are the objectives of chemotherapy? One, complete remission, that is cure. Second, partial remission. Partial remission means tumor size will be reduced, survival will be increased. Third is a prevention of recurrence. Adjuvant therapy is given, and fourth is a palliation, that means symptomatic relief and improved quality of life. So these are the objectives of chemotherapy. Whenever you are writing about the chemotherapy, you should describe the cell cycle, first phases of the cell cycle. Okay, because drugs are acting on the different phases of the cycle. Okay, so what are the different phases? There is a G1 phase during which cell growth happens. Then there is a S phase where there is a DNA synthesis. G2 phase, it is a stage before mitosis. So the cell is preparing for the mitosis. Then it is followed by the mitosis. And G0 is a resting phase. Okay, so the cells, there are few cells which are in the resting phase. When the cell is going to divide, it enters into the cell cycle. So the first is a growth phase. Then there is a synthesis of the DNA, that is the S phase. Then here is a phase before the mitosis where the cell is preparing for the mitosis to happen, and then there is a mitosis. Okay, and the cell can go into the resting phase anytime. Okay, so there are certain points which you should remember. Tumor cells divide at the same speed as normal cells. Tumor cells do not have the high rate of division. The speed of division of the tumor cell is same as normal cells. Cancer growth occurs due to the loss of growth control and not faster cell cycle. Okay, and cytotoxic drugs mainly act on the actively dividing cells. They are mainly acting on the actively dividing cells. There are certain drugs which are acting on the resting cells also, but most of the cytotoxic drugs are acting on the actively dividing cells. Cells in the G0 phase are relatively resistant. Okay, now what are the types of normal cells? If you see the normal body cells, you will find there are three different types of cells. One, proliferating cells, which are bone marrow, intestinal mucosa, quiescent, the liver cells, and static, these are the neurons. There are certain concepts, important concepts, which you should note down and which you should remember. One is a growth fraction. Growth fraction means out of the cells which are available, how many or what percentage of the cells are actively undergoing division. Okay, so growth fraction is the percentage of tumor cells actively undergoing division. Okay, doubling time. Time is which is required for tumor mass to double in size, that is the doubling time. Third is a Gompertzian growth. Okay, this also you should remember. As the tumor size increases, the growth rate decreases. So mass doubling time will be more and more longer as the tumor size is increased. Okay, because the doubling time will also increase. Okay, the tumor size increases, but the growth rate decreases. Okay, so that is the Gompertzian growth. Okay, now as I mentioned, the cell cycle, there are certain drugs which are acting in a specific stage of the cell cycle, while there are some non-specific acting drugs. So there are cell cycle specific drugs and cell cycle non-specific drugs. Okay, so the cell cycle specific drugs will act on a specific phase. This also you should remember, which drug act on which phase. Okay, so this you can take the photo if you want. G1, that is the growth phase, actinomycin D will act. Then synthesis phase, where the DNA replication happens. Here methotrexate, 5-fluorouracil, doxorubicin is acting in the synthesis phase. Then you have G2 phase, where bleomycin etoposide is acting, and M, that is the mitosis phase, in which your vinca alkaloids, that is the vincristine, vinblastine, and taxanes, that is paclitaxel and all, these are acting in the mitosis phase. Okay, so mitosis phase drugs, which drugs? Vinca alkaloids and taxanes, you should remember. Okay, and methotrexate and all, doxorubicin, etc., synthesis phase. Okay, then you have certain drugs which are cell cycle non-specific. Okay, they will act on both resting and dividing cells. Examples are cyclophosphamide, cisplatin, carboplatin. So these are cisplatin, carboplatin we are frequently using in the ovarian cancer. Okay, so these are cell cycle non-specific. They are best for bulky, slow-growing tumors. Okay. Another important concept which you should understand in chemotherapy is a log kill hypothesis. Okay. So what is log kill hypothesis. When you give the chemotherapeutic drug in a specific cycle, each chemotherapy cycle will kill a constant fraction. That means constant percentages of the tumor cells rather than a constant number. Okay. So when you give a cycle, suppose a particular drug is killing 90% of the cell in each cycle. So if there are 100 cells, 90 cells will be killed, 10 will be persisting, which may grow if you don't act on them. So if you give another cycle, out of 10, 9 will be killed, 1 will remain. Okay. So this concept of log kill hypothesis, you should understand that each chemotherapy cycle kills a constant fraction of tumor cells rather than a constant number. Okay. Suppose there are 10 raised to 12 cells. Okay. And 99% cells are killed, then what is remaining is a 10 raised to 10 cycle, because 1% of 10 raised to 12 is a 10 raised to 10. Okay. So in the next cycle, again, 10% will remain and 1% will remain. So 1% of 10 raised to 10 is a 10 raised to 8. Okay. So that will be cells will remain. What is the importance of this? This is the basis for repeating the cycle. That is why you need to repeat the cycle, and it also explains the benefit of combination chemotherapy. Okay. So these are the basis for combination chemotherapy also. Okay. Then you will be writing about the principles of chemotherapy. Rapidly growing tumors will respond better. Constant fraction of the cells killed with each dose. This is what also we have seen. Then response will depend upon the tumor size, growth rate, growth fraction, drug type, host immunity. These are the factors affecting the response. High dose intermittent schedules will improve the tumor kill. Okay. So you should give high dose and intermittent schedule. Combination chemotherapy is preferred because you are using the drugs which are acting synergistically. They will have different side effects, different mechanism of action. So this synergistic action will be more useful. Then dosage is adjusted according to the patient tolerance. Okay. Now you should also understand the combination chemotherapy, advantages of combination chemotherapy. Why we combine chemotherapeutic agent? Advantage is that because of this you get a higher tumor cell kill, synergistic effect, act on different cell cycle phases. Drugs are acting on different cell cycle phases. Okay, so there will be synergistic effect. They will delay the drug resistance and allows the lower toxicity. The principle for combination chemotherapy, what is the principle? Every drug should have proven single agent activity. So whatever is the combination which we use, every single agent should have an anti-tumor activity. Okay. Then different mechanism of action should be there. Then different toxicities they should have and different cell cycle specificity. If the toxicity is same, then you are going to have the toxic effects of the both drugs together. Okay. But if the toxicity is different, the tolerability will be more and better. Okay. So this is what is the principle for combination chemotherapy. Then how does the drug resistance develop? If you can remember this well and good, there is an increased DNA repair, decreased drug uptake, increased target enzyme, increased drug degradation, and spontaneous tumor mutation. So these are the mechanisms for the drug resistance. Now, how these cytotoxic drugs are classified? Okay, one is alkylating agents. Alkylating agents are cell cycle non-specific. How does this alkylating agents act? They cause the cross-linking of the DNA. Normally, these cells should divide. These cells divide, cancer cells. So for division to happen, what should happen first at the level of the DNA? DNA is a double-stranded structure. So there is a cross-linking. These two strands should get separated. So these two strands should break. But what does these alkylating agents do? They keep the cross-linking together. So they do not separate. So once they do not separate, that will inhibit the DNA replication. Then the cell will body will identify that this cell is not dividing because there is some defect, and that will lead to the breakage of that particular DNA strand. Okay, so the drugs which are acting in this particular fashion are the cyclophosphamide, ifosfamide, melphalan, thiotepa. These are the drugs, are the alkylating agents which are cell cycle non-specific. Then another platinum compounds like cisplatin, carboplatin, oxaliplatin, etc. These are cell cycle non-specific alkylating agents. Another category is the antimetabolites. Antimetabolites are the cell cycle specific drugs, and antimetabolites will act mainly at the DNA synthesis level. Okay, so inhibit synthesis of the nucleic acid. Examples: methotrexate, Folic acid antagonist inhibits dehydrofolate reductase 5-fluoroacyl 5-FU, which is a pyrimidine analog, blocks the thymidylate synthesis. Then 6-mercaptopurine, purine analogs, and gemcitabine used in ovarian, breast, and cervical cancers. So at least methotrexate, 5-fluoroacyl, 6-mercaptopurine, these three drugs you should remember, which are antimetabolites. Then third category is anti-tumor antibiotics. So they inhibit the DNA replication, cause DNA strand break. Examples are the actinomycin B, bleomycin, doxorubicin, mitomycin C. These are the antibiotic category of anti-cancer drugs. Then plant derivatives and taxanes. Okay, vinca alkaloids. Okay, these are called as they. How do they act? They cause the spindle poison. They are causing the spindle acting at the level of the spindle formation. Okay, spindle poisons, arrest mitosis at metaphase stage. Vincristine, vinblastine are the examples. Then you have taxanes in this particular category. They will stabilize the microtubules, prevent depolymerization. Examples are the paclitaxel, docetaxel. Then you have a camptothecin analogs, that is topotecan, irinotecan. They inhibit the topoisomerase 1. Okay, and other is a etoposide. Then you have a hormonal therapy in which we are using progestins, medroxyprogesterone acetate, magistral acetate, hydroxyprogesterone caproate. Then you have anti-estrogen, that is tamoxifen, GnRH agonist, leuprolide. Miscellaneous like hydroxyurea, which is a radiosensitizer, and hexamethylamine. Okay, so these are miscellaneous category of drugs, and there are certain biological agents like interferon, Mullerian inhibiting factors. These are also anti-cancer agents. Okay, so another thing which can be asked in the viva, or you can write in the theory also, is the pre-treatment evaluation. So we have seen a cell cycle, we have seen cell cycle specific drugs, we have seen cell cycle non-specific drugs, we have classified these drugs. Okay, mechanism of action we have seen. Then giving the chemotherapy. So pre-treatment, what are the things which we will do? We will do the hematological investigations such as CBC, platelet count should be more than 1 lakh, renal function test, urea, creatinine clearance, LFTs, bilirubin, liver enzyme, serum proteins, cardiac function, ECG, ejection fraction, especially with doxorubicin. Remember, doxorubicin is known to cause cardiomyopathy. So ECG, ejection fraction, 2D echo, very important. Bleomycin is known to cause pulmonary fibrosis. So pulmonary function you have to do. Electrolytes, urine culture sensitivity, throat swab. These are the investigation or the pre-treatment evaluation. Another important concept in chemotherapy you should remember, how do you calculate the dose? Dose is calculated by using body surface area. Okay, then why we use body surface area? Because it is a better predictor of toxicity than the body weight. Okay, so body surface area is a better predictor of toxicity than the body weight. It reflects the cardiac output and the blood flow. Okay, and there is a less variation during the treatment, because patient may lose the weight during the treatment also, but the body surface area, there is a little change. Okay, so go by the body weight. Okay, so body surface area includes the height and weight. It is a better predictor of body size as such, better predicts the drug toxicity, better reflects the blood flow and organ perfusion, and more accurate chemotherapy dosing, and less variation during the treatment. Okay, then what are the routes of administration? You can give oral, intravenous, intraarterial, or intraperitoneal. Okay, what are the objectives of with respect to the timing for this chemotherapy? One, you can give a primary chemotherapy, that is the main treatment for that particular cancer, like GTD. Okay, where we are giving the primary chemotherapy. Then you have adjuvant chemotherapy. Okay, after surgery or radiotherapy. Prevent recurrence. Okay, neoadjuvant chemotherapy before definitive treatment shrinks tumor. Neoadjuvant chemotherapy. Okay, then you have intraperitoneal chemotherapy, small residual ovarian disease. You give intraperitoneal chemotherapy. Okay, then how do you assess the response? So there should be some internationally acceptable criteria for assessment of the response. So it is a RECIST, that is the response evaluation criteria in solid tumors. So what are the categories? One, there can be complete remission, that is CR, that is the disappearance of all target lesions. Then there is a partial response. Partial response means you give the chemotherapy and more than 30% reduction in the tumor size. There is no disappearance of the tumor, but reduction in the tumor size is more than 30%. That means there is a partial response. Then there is a progressive disease. What does progressive disease mean? You are giving the chemotherapy, but still there is an increase in the size by 20%. So if the tumor mass is increasing by 20% in spite of chemotherapy, that means there is a progressive disease. And another is a category is a stable disease, that is SD, that is neither progressive nor partial response. Okay, that is called a stable disease. Okay, how do you monitor the therapy? By clinical examination, by doing CT scan, MRI, tumor markers, CA125, beta HCG, PET scan, etc. Then what is the toxicity of chemotherapy? That you will write. Gastrointestinal effects such as nausea, vomiting, stomatitis, diarrhea. Management is with ondansetron, dexamethasone, and metoclopramide. On bone marrow, you have anemia, neutropenia, thrombocytopenia. Management is by blood transfusion, platelet, granulocyte colony stimulating factor, granulocyte monocyte colony stimulating factor can be given. In hairs, you have alopecia. Usually, it is reversible. In skin, there can be dermatitis, pigmentation, extravasation, skin necrosis. In cardiac, especially with doxorubicin, you will have cardiomyopathy, arrhythmias. Liver, mainly methotrexate, hepatitis, elevated liver enzymes. Lung, because of the bleomycin, there can be pulmonary fibrosis. In nervous system, mainly because of the cisplatin, peripheral neuropathy, ototoxicity can be there. Then renal, again, cisplatin is a nephrotoxic, ototoxic, and peripheral neuropathy. These are three things about the cisplatin you should remember. Okay, so when you talk about ovarian cancer and cisplatin side effects, you should be able to describe. Prevention, hydration, and mannitol diuresis. So that is what is the method for prevention. Hemorrhagic cystitis, very specific for cyclophosphamide and ifosfamide. Okay, it is prevented by giving mesna. Okay, on gonars, what is the effect of the chemotherapy? There can be amenorrhea, premature ovarian failure, infertility. If there is a pregnancy, there can be teratogenicity, and there can be second malignancy, especially with male phalan, there can be leukemia. Okay, so common drug toxicities which you should remember, and this may be important from viva point of view, like doxorubicin has got a cardiotoxicity, cardiomyopathy it can cause, bleomycin will lead to pulmonary fibrosis, cisplatin we have already discussed, it will cause peripheral neuropathy, it will cause ototoxicity, and it will cause nephrotoxicity. Okay. Then cyclophosphamide, hemorrhagic cystitis, ifosfamide, hemorrhagic cystitis, methotrexate, hepatitis, stomatitis, plaque cell, alopecia, neuropathy is known to happen, carboplatin, myelosuppression. Okay, so coming to the chemotherapy in various malignancy, gynecological malignancies. In cervical cancer, chemotherapy can be used along with radiation, that is concurrent chemoradiation can be given. Then which drug we use? Cisplatin-based regimens are there. Neoadjuvant therapy can be used, and palliation in recurrence. Okay, for endometrial cancer, progestins can be used, cisplatin, doxorubicin, ifosfamide, tamoxifen, and leuprolide. These are the things which are commonly used. In ovarian cancer, first line for epithelial cancer is a paclitaxel and carboplatin. That is the first line for epithelial. And other drugs which can be used are cisplatin, cyclophosphamide, adriamycin, and gemcitabine. So these are the drugs which can be used for ovarian epithelial type of cancer. Okay. Another regime is a BAP regime, which is very commonly used for germ cell tumors. For germ cell tumors, BEP, bleomycin, etoposide, and platinum, cisplatin-based regime. Okay, germ cell tumors. For dysgerminoma, VBP, vinblastine, bleomycin, cisplatin. For GTN, methotrexate, actinomycin D. Multi-agent regimens for high-risk disease. Okay. So formalities during chemotherapy administration. So these are the practical points which you should remember. Never mix drugs in the same infusion. Okay, they are to be given separately. Then flush the IV line with normal saline between the drugs. Wash vein with saline after administration. Avoid extravasation and administer antiemetics before chemotherapy. So take home message is that what you should remember from this chemotherapy, and you should write in the examination. One is a log-kill hypothesis. Chemotherapy will kill the constant fraction of the tumor cell. Then growth fraction, these are the percentage of actively dividing tumor cells. Then Gompertzian growth, larger tumors will grow more slowly. Then cycle specific drugs will act on the proliferating cell, while cell cycle non-specific drugs will act on the resting and dividing cells. Body surface area is used for chemotherapy dose calculation. Paclitaxel and carboplatin is the first-line chemotherapy for epithelial ovarian cancer. BP regime is used for malignant ovarian germ cell tumor. Mesna is used for prevention of cyclophosphamide and ifosfamide-induced hemorrhagic cystitis. Hydration plus mannitol will reduce the cisplatin nephrotoxicity. And ondansetron and dexamethasone are standard antiemetics for hematogenic chemotherapy. So that finishes the topic of chemotherapy in gynecology. Thank you.